Polycystic ovarian syndrome, or PCOS, is a complex chronic disease affecting metabolism, fertility, and menstrual cycles of females, as it directly relates to an issue with ovulation and hormone imbalance. It affects women through their reproductive years, usually starting between the ages of 12 and 20. It can affect them all the way up until the age of around the mid-40s, and the typical symptoms change with age. PCOS can be diagnosed in young girls as little as 10, but it is most common in fully developed women between 20 and 30 years old. It has lifelong effects. PCOS has a lot to do with imbalanced steroid hormones, so the menstrual and ovulatory issues seem to cease on their own with the natural course of menopause later in life. However, long-term risks such as cardiovascular diseases and cancers tend to appear more often in postmenopausal patients. It is manageable with many interventions, but sadly, there is no cure. This presentation will talk about PCOS, its clinical features, its prevalence, and a treatment option. It will also undergo a case study of a UIT student who happens to suffer from this disorder. Overall, it has a 10% prevalence worldwide, and 50% of cases go unnoticed. Because of this, the prevalence could actually be very different from what the research shows. Along with this, there's a 50% risk for diabetes in patients with PCOS and a threefold increased risk for endometrial cancer due to exposure to additional hormones through the hyperandrogenism clinical feature, which causes endometrial thickening. However, this is generally detected early, as PCOS women must undergo regular ultrasounds and usually need more gynecological visits to manage their condition. This condition affects women of all ages. It generally begins with the onset of puberty, with the elevated androgens being the first clinical symptom noted, such as elevated testosterone and androstenedione, which are mainly male hormones. This can occur as early as the age of 10 years old, and other complications are common among the pubescent age, such as obesity, which has a 65% prevalence among PCOS women, and diabetes, which has a 20% prevalence among PCOS women. These are usually all linked to insulin resistance, or IR. IR is found in approximately 50% of the population with PCOS, and it's thought to be one of the key contributing factors to developing the condition. It is similar to diabetes and results in chronic fatigue, interrupted digestion, and stress in the body due to the body's inability to uptake glucose into the cells due to imbalanced insulin to insulin receptor ratio. As PCOS is most commonly diagnosed in adolescence, the most typical presentation is an irregular or absent period for quite some time, elevated androgens, which would show up on the blood test and could have also been present for a very long time. Whether or not that person got many blood tests throughout childhood would leave that a mystery. And multiple immature follicles in the ovaries, which would be diagnosed on ultrasound. This is also something that commonly goes unnoticed until somebody presents with deeper pain. Cysts in the ovaries are common, with rupture and ovarian torsion being rare but prevalent complications. PCOS women are twice as likely to be admitted to an emergency department as their healthy controls. The most common costly complications of PCOS are diabetes and infertility. Infertility is 10 times more common among PCOS women due to their tendency not to ovulate, usually linked to the ovarian cysts presenting follicles for maturing and releasing an egg, and a hormone imbalance presenting follicle-stimulating hormone from doing its job. 25% of PCOS women cannot have children. Later in life, more sinister secondary conditions tend to arise, such as atherosclerosis, endothelial dysfunction, myocardial infarction, and cancer. It is more commonly reported in the US, UK, Australia, Mexico, Spain, and Greece, but research still heavily lacks about the true etiology of this disorder. It costs the US $4 billion and Australia $8 million per year to treat. Now I'm going to take a break and present you with a case study about me. A UIT student. Now this is a few years ago in the past, so I was in second year university and I was 19 years old. And as a brief history, I had been menstruating for 7 years. I was very muscular and had a very high appetite compared to what I have now. My past medical history was having irregular and long periods, which were sometimes absent, especially when I was younger, in the pubescent age. extremely painful pelvic areas during periods, sometimes during ovulation, and intense cramping, which always required anti-inflammatories from the drugstore. And I feel like it led me to a bit of a mood imbalance as well. One day, I presented to the ER with immediate onset extreme pains in my left side, which ruled out any digestive organ issues, including appendicitis. Now, often when you go to the ER for complications in your lower body, they always assume that it's appendicitis. So when you're on the left side, there's a lot less organs that can be there, causing you the pain. So it's a little bit harder for them to figure out what's going on. So either way, they checked me for many things, including kidney stones, STIs, UTIs, gallstones, bloodborne infections, and pregnancies, and they all came back negative. There are many different variations of PCOS. Most notably, some women do not suffer from the insulin resistance side of the disorder and have an easier time with digestion, metabolism, and weight management. However, having a normal body weight does not mean that they are not suffering from some degree of insulin resistance. There's a strong link between a healthy and anti-inflammatory diet and relief from PCOS. As mentioned, the main symptoms of PCOS are male to female hormone imbalance favoring testosterone and other androgens, menstrual irregularities including a lack of a period, a really long period, delayed periods, painful and clotted periods, and heavy cramping, and ultrasounds that would show enlarged ovaries or those with the presence of multiple follicles and/or cysts. It is important to note that many women suffer from only 2 out of the 3 main symptoms and still meet the criteria for a diagnosis. It is possible to have polycystic ovaries without being diagnosed with polycystic ovarian syndrome and to have insulin resistance that does not cause PCOS. Other symptoms not necessary for diagnosis, but which are commonly associated, include male-like physical features such as having a high muscle mass and a deep voice, hirsutism, which is a male-like hair growth pattern, heavy acne, weight gain, trouble shedding visceral fat, which is usually linked to insulin resistance, high levels of luteinizing hormone or irregular luteinizing hormone to follicle-stimulating hormone ratios, and the complexities of ovarian cysts. When all hormones work together in synergy, in a woman, ovulation occurs. When disruptions in ovulation occur, cysts can form through 2 major functional routes, or the follicles can simply fail to mature and release an egg and remain in the ovary. The presence of follicles is a classic symptom of PCOS, despite the women still potentially having normal menstruation and lacking cysts. Polycystic ovaries result in the ovary swelling and appearing with the presence of multiple follicles, which are immature and did not develop and release an egg. Many kinds of ovarian cysts, but only 2 are important in PCOS. Functional cysts appear and disappear on their own, generally without surgical intervention. They are either follicular, which is a cyst that surrounds a follicle which failed to release an egg, or luteal, which is a cyst that surrounds the corpus luteum, which normally forms and disappears after the egg is released. Luteal cysts are more commonly ruptured because they are filled with blood and generally grow larger than the follicular cysts, causing acute abdominal pain and cramping, and generally sending women to the ER. All cysts have the potential to rupture, which can cause extreme excruciating pain. The non-functional cysts are generally made of fat cells and can be cancerous in certain conditions. These are hardly ever found in PCOS. Some of the hemorrhagic cysts, which are cysts that have begun to rupture, grow so large that they require surgical intervention to remove or to fully rupture. Ovarian torsion is caused by a lack of blood flow to the ovary when the cyst becomes so large in size that it actually twists the ovary itself and causes major pain. These situations can sometimes require surgery to return the ovary to its normal position, and if it lacks oxygen for too long, then necrosis can occur. This can become a serious medical emergency requiring immediate oophorectomy, and ovarian death is quite common in these situations. Me again. I'm still in the hospital and I still have no idea what's wrong. I'm on painkillers, I'm in a ton of pain, and I'm freaking out. So I went in to get an ultrasound, and the test showed a positive diagnosis of an ovarian cyst. Originally, they actually could not figure out exactly what kind of cyst it was and were certain that it was a non-functional cyst, but I then had to go and get another diagnosis, which confirmed that it actually was a functional cyst. And on this ultrasound, they noticed the presence of multiple follicles on both ovaries, which is sometimes referred to as a string of pearls and is another very classical symptom of PCOS. So, after this, they recommended testing for PCOS. What? At this point, I've never heard of PCOS, never heard of a follicle on an ovary or a string of pearls, and have no idea what anyone's talking about. I had no idea that I was about to be diagnosed with a disorder that was already affecting my entire life and would continue to affect my entire life. But here's more. Lucky me, I got to undergo more tests, which actually proved that I in fact do have PCOS. My blood test showed elevated luteinizing hormone levels, extremely elevated testosterone levels, which were 2 times the healthy woman level, extra dihydrotestosterone, which is a potent form of testosterone, and many, many other androgens, which were also high, while my estrogen and progesterone levels were quite low, signaling likely infertility. Ultrasounds showed the string of pearls, a ruptured cyst, presumed ovarian torsion, which is what actually sent me to the ER the first time. They can't really prove this after the fact, after the condition resolved itself, but usually on an ultrasound, a lack of blood flow to the ovaries would indicate ovarian torsion or the past history, so extreme abdominal pain, vomiting, nausea, dizziness, fainting, etc., and famously ER admittance. So that is what they diagnosed me with. My personal history reflects the menstrual abnormalities and pain since grade 7. This was previously ignored by my doctor because it can take many years for a menstrual cycle to regulate, but truthfully I was having issues with it ever since I was having puberty, ever since that onset. So it makes a lot of sense now at this point what I've been suffering with my whole life. There are many hypotheses as to what causes this disorder. It is certainly genetic, as males can carry it and pass it on to their female offspring. New research is even showing that there might be metabolic issues in men who carry PCOS, although they don't have ovaries and do not have any of the menstrual or reproductive issues that the females suffer with. There's currently no diagnosis for that, but the research is currently underway. The 2 main theories of PCOS begin first with elevated androgens, which is caused by an intrinsic cellular defect, which triggers anovulation and cysts, and due to the presence of multiple follicles on the ovaries, hormone-related changes arise, such as infertility and amenorrhea. Another popular theory is the insulin resistance theory, again caused by an intrinsic cellular defect. This triggers obesity and diabetes risk, puts the body under extreme stress, and triggers excess adrenal output, which triggers hyperandrogenemia and anovulation, which disrupts menstruation, mood, and causes other hormone changes such as hirsutism, acne, and visceral fat gain, all of these which are seen in PCOS. Another less popular theory is that bicornuate uterus and other uterine abnormalities are actually to blame for this, as around 70% of cases of women with uterine congenital issues are also presenting with PCOS. However, the research in this area lacks as well. This condition has many forms, many symptoms, many different kinds of diagnosis, and requires multiple levels of treatment. Most notably, it's usually diagnosed by a general practitioner such as a family doctor or somebody who works in the emergency room, depending on the immediate presentation of symptoms. Usually, the family doctor responds to amenorrhea, but the emergency room doctor might be treating you for an ovarian cyst or ovarian rupture. Regardless of what you present with, the doctor will generally start by prescribing you with birth control in an attempt to keep the period and hormone cycle regular. Throughout this journey, you will be experiencing many diagnostics and diagnostic staff, such as sonographers, MRI techs, and radiologists. as there's a lot of diagnosis that goes into this, and constant monitoring is necessary to make sure that nothing is progressing or getting worse. A gynecologist is very, very useful in PCOS because they can analyze your diagnosis and your radiology results. They can help you treat fertility issues and can prescribe different medications to help to control the cysts. So there's something called spironolactone that is an ovulation regulator that's commonly prescribed. And they can also organize surgical interventions when necessary. For example, if you were suffering with chronic cysts and you had one that was beginning to rupture or swell and they wanted to go in and pop it, that's something that they can do at the gynecologist office. An endocrinologist is especially important when dealing with the side with insulin resistance, but they can also offer assistance in controlling the androgen excess through hormone replacement therapy, or offer more natural interventions, most notably inositol, saw palmetto, Vitex, and chasterberry supplements, which have been linked to relief from PCOS. Overall, it involves many health practitioners, and there's no cure, but there are many different ways to manage the symptom to make life more comfortable for women suffering with PCOS. While there are quite a few medical options that doctors can prescribe a patient to try and control the side effects from PCOS, there's nothing that really targets the root cause, considering research doesn't even know what the root cause is. PCOS is simply a cluster of symptoms with many hypotheses and no actual cure. In recent years, plenty of research has been conducted to show a link between a natural supplement called inositol, which is a vitamin B compound, and reducing the symptoms of PCOS. Its research shows benefits on restoring ovulation, inducing fertility, improving mood balance, reducing male androgen levels in women, and affecting the fat metabolism in the insulin-resistant population with PCOS. Myo-inositol, which is its full name, is responsible for cellular messaging, regulating thyroid-stimulating hormone, follicle-stimulating hormone, and insulin, which is why supplementation is thought to have such high metabolic benefits in PCOS. It seems to target all of the root causes of PCOS, even the ones that don't affect each individual, such as insulin. Its derivatives aid in transporting glucose into the cells, which is very difficult with a defective insulin pathway in IR patients. It also helps to reduce the fatty acid release, which increases available glucose to the body. According to a 2018 study, 37 women with PCOS were ordered to take inositol supplements for 2 times a day for 3 months. These women had to suffer anovulation and infertility for more than 1 year to be included in the study. It is thought that restoring ovulation would repair infertility in this condition. According to the trial, 23 out of the 37 subjects, or 62% of participants, ovulated after 3 months, while the other PCOS subjects did not. However, the presence of lipids was reduced in significant proportions of all the patients, but this study did not look into the other features of PCOS that inositol has been thought to manage, such as insulin resistance and mood disorders. It is unclear as to whether this is a perfect solution for treating the root causes of PCOS. Obese patients were excluded from this study due to the potential for interference with pregnancy relating to body weight, so it cannot assess its impact on weight management and obesity reversal. However, it did not appear to have any negative side effects on the study participants. Overall, inositol is reported to be an effective tool for restoring ovulation in women with PCOS who are infertile, suffering with cysts, and any other complications due to ovulation. Research still lacks about how inositol actually affects the mood positively and affects the weight accumulation of obese PCOS patients, but the potential for the research is there due to the underlying physiology of inositol supplements. Now, I guess I am living proof that inositol does work. Thanks to a 6-month regimen of taking inositol regularly, coupled with other supplements that target the period and the hormones more, and a change in diet and lifestyle, my condition has completely changed. The most notable sign is that I've had normal periods for the last 2 and a bit years, which indicates that ovulation is occurring again. And because of this, I've actually had no painful cysts since 2018. I still have multiple follicles showing up on my
Ultrasounds with this is a lot less than there used to be, and I definitely don't suffer from rupturing cysts anymore. I still experience fluctuating hormone levels and dietary issues, but I've had no increases in weight gain or any insulin resistance type symptoms. I've been successful through regular visits to the gynecologist to check up on the ovaries, the naturopath to give me all the supplements for my hormone levels, and my family doctor just to give general updates on the condition and general lifestyle advice. Overall, PCOS can be a sinister condition, but with the right intervention and medications, or supplements if that's what you choose, the condition can be manageable and anyone can still live an active and healthy life while suffering with this disease. Thank you for watching my presentation.